Welcome to the video on pathology of coronary artery disease. In addition to going through the pathology, we're going to examine risk factors and then describe in more detail the two main types of clinical manifestations of coronary artery disease that we see, which are angina pectoris and myocardial infarction. This slide should look pretty familiar to you because it's definitely the same type of process that we described when we looked at peripheral arterial disease and atherosclerosis. Now we are essentially looking at the exact same process, but it's happening instead of to the peripheral arteries, to the very central arteries that serve the heart, or the coronary arteries. So again, coronary artery disease. And this is the #1 cause of sudden death in adults in the U.S. It's also the 5th leading cause of death for even people who are very young, ages 15 to 34, 3rd leading cause of death in those 35 to 44, and 2nd leading cause of death for those aged 45 to 64. So we can see that this is a big cause of mortality in the United States, and so one that we in physical therapy we're going to be dealing with a lot. So as we can see, we review the normal artery, and remember it's got a thick muscular wall, and then the inner layer, the basal layer, is very, very smooth, normally very smooth. What happens though, often over time and with risk factors that we'll talk about in just short order, we can see that that very smooth lining can become damaged. And so with this damage, we can see kind of a combination of things happening. We get some blood clot because of the response to the damage. We get fibrin or fibrous tissue building up because it's trying to repair the damage, so we kind of have some scar tissue. And then of course we can get some fats or lipids in there as well. So we have this combination of the damage, and it's starting to catch on the blood proteins, or the fat proteins that are flowing through the blood. And again, we have the fibrous tissue that's trying to repair the damage. So all that kind of collects together and slowly creates plaque that gets laid down in the coronary arteries. Over time, as the size of that clot grows, obviously the size of the lumen gets smaller and smaller, and so then we see that there are areas of the heart that aren't going to be supplied very well by blood flow. And if you've already watched the video on cardiac anatomy and physiology, you would have seen a description of coronary artery vessel flow into the heart. So again, ultimately, the result we have is less blood flow and decreased oxygen distribution. And as we mentioned, the heart is really dependent upon constant flow of oxygen for its aerobic metabolism. As a consequence, we see patients who demonstrate a variety of either impairments, functional limitations, or even disabilities. So some of the things that we see in someone who's got lowered blood flow to the heart, we're going to see that they do not respond appropriately during times when there's increased oxygen demand. So what we would typically expect, let's say somebody's exercising, we expect the heart rate to go up and that we can meet that oxygen demand. That heart rate response may be abnormal. Similarly with the pulmonary response and blood pressure responses. So we see abnormalities that we wouldn't expect to see during times that we have increased oxygen demand. In addition, part of this abnormal response could be cardiovascular symptoms, and we'll go through what some of those symptoms are. The person may definitely show what we call impaired aerobic capacity, in other words, low endurance, and we'll talk about what METs are in just a little bit. This may lead to the inability for them or difficulty for them performing normal ADLs. So this is the person who they get up, they shower, they dress, and then they have to sit down and rest because they're so tired. Similarly, they may see that in work roles. They can't do yard work without getting very fatigued. And it might surprise you. You might think, well, why wouldn't someone know this is going on? But this is a very, there aren't a lot of overt symptoms. This is a very silent and stealthy process. And so people over time will complain more and more of fatigue, kind of getting tired out. They think they're just run down, and they may not really be in tune to the fact that they are developing some very clear symptoms of coronary artery disease. So this is an actual photograph of an actual cross-section of an artery, and you just get the sense that that tissue, that clot or that atherosclerosis is just brittle. It looks brittle and hard, and that's exactly what it is. Here's a picture showing the coronary arteries going to different areas of the heart, and it's very typical to have this buildup kind of occur at the place where there's a junction. In other words, a branching off from one artery to another. You can see here after a little bend in the artery, but a lot of key areas where you might see, and so this is just illustrating different percentage of blockages. And I'm sure you've heard, people's stories where they talk about, it was 80% blocked or it was 90% blocked. Well, vessels that are blocked that far don't allow very much blood flow in, so this is what they're talking about. So let's talk about some of the risk factors. And just to review, a risk factor doesn't mean necessarily a cause, but a risk factor is not a symptom at all. So it's not, don't think symptom when you hear risk factor. It's closer to cause than anything. But we can't really say there's a causative effect. We don't have enough evidence, or we don't have enough research to say that. But what we do know is it's very, very highly associated with it. So, smoking. Coronary artery disease is very, very highly correlated with people who smoke a lot. So we definitely want to counsel any patients that we see, especially those with coronary artery disease or who have other risk factors, to stop smoking. High blood lipid levels are also highly associated with coronary artery disease. So just to review, there's a couple different elements we can look at with blood lipids. So these are the fats traveling around. One form of fat is cholesterol. There are two basic divisions of cholesterol: high-density lipoproteins and low-density lipoproteins. The high-density ones are the good ones. The low-density ones are the bad ones. They're the ones that can float around and float all over and get caught on the walls. So we want higher levels of HDL, lower levels of LDL. But added together, we want to see a total cholesterol that's under 200. So normal total cholesterol would be anywhere from 100 to about 199 milligrams per deciliter. Of that, again, we would like to see the high-density lipoproteins be above 40 milligrams per deciliter. We want to keep the low-density lipoproteins under 130. Another form of blood lipids or fats that are in the blood are triglycerides, and we want to see those under 150 milligrams per deciliter. Obesity, we know, is a risk factor for patients developing coronary artery disease as well as inactivity. So you can see here kind of a bad combination. He's just so worn out he can't even reach his television remote. And we can see maybe some poor nutritional choices there as well. We want to make sure people are staying active from the start, so we don't want to even give them a chance to develop. Stress is another risk factor. Now the risk factors I've just mentioned are what we would call modifiable risk factors, or those that we have control over and could change. The ones we can't change, of course, are our age, the sex that we were born, our family history. If we have a brother or a father or mother with coronary artery disease, we can't do anything about that. And then other elements of our own medical history. So for example, if we have hypertension or diabetes, we can't really change that. So the three major risk factors are high blood pressure, high blood fat levels, and smoking. And the presence of any one of the risk factors that we mentioned has a synergistic effect. In other words, it's not just a linear increase, it's an exponential increase in the chance that somebody's going to develop coronary artery disease. So I put here in two examples of risk assessments for cardiovascular disease, and I'm going to, as part of our lab activities that we're going to do later together, I'm going to have you go ahead and go in and do your own, assess your own risk. It doesn't matter to me which one you use, but it'll give you a little bit different value. If you don't know your cholesterol levels, then you're just going to have to estimate that as part of the tool. So do the best you can, but go ahead and either pause it now or at the end of this video, go ahead and go in and assess your risk for coronary artery disease. What I want to do now, though, is talk about the two main types of problems we see with patients with coronary artery disease. First one is angina or angina pectoris, and then the second one we're going to talk about is myocardial infarction. So angina pectoris literally means strangling of the chest, and this is ischemia that's caused when either generally during a time when the demand of activity of the heart muscle exceeds the ability of the coronary arteries to supply it. Though this is a temporary situation. So it's much like a TIA or a transient ischemic attack you may have talked about in neuro. Symptoms for this, you probably remember these from going through CPR. Because we're talking about ischemia, that's going to be a sharp pain. So the person may feel sharp chest pain, or they may feel pressure in the chest. Sometimes they'll describe it as an elephant sitting on their chest or a tight band around the chest. Now remember, because the dermatomes or the spinal level that serves the heart comes into about the T4 or T5 level, you may also have the person perceiving sensations coming from other areas in the body. So the jaw or the throat is a common area, the shoulder blades, like around the scapular area, and the left upper extremity. If you think about where T1 is in that upper area of the arm, so really anywhere from T1 through T5, that could be the same place the afferents come in from the heart, go into the spinal cord. So again, the brain might be perceiving symptoms in other areas. And this is also part of why sometimes people don't recognize or maybe are in a little denial about the fact that they're having cardiac symptoms, because it doesn't necessarily feel like what they would perceive as heart trouble. It might feel like achiness in the shoulder or achiness in the arm, and they may not correlate that. If we would look at EKG changes, that ST segment, I talked about that when we did the EKG segment video. The EKG, the ST segment is very sensitive to ischemic changes, and so you may see on EKG ST segment depression. So we have three forms of angina: stable, unstable, and variable or variant angina. So I think it's kind of easy. Stable angina would be that which is very predictable. It's typically caused by exercise or stress, and stopping that exercise or that stress often makes it go away. So it's very predictable, it's very easy to associate with it with a specific activity or a certain activity level, and then it goes away as soon as that's done. Another way that it can easily be relieved is through the use of medication. Typically we use nitrates or nitroglycerin. Sublingual means under the tongue, so they might use a nitroglycerin tablet, put it under their tongue when they're experiencing their symptoms, and then that will relieve them as well. So unstable angina is the term they give if this angina has occurred for the first time, so they can't really tell if it's typical or not yet, or if it occurs at rest. So this isn't great, because especially if it's occurring at rest, that makes it more unpredictable. They don't really know what's causing it, and it makes it a little less responsive to medication as well. And then finally we have variant angina, also can be rest angina, and this can be caused by coronary artery spasm. So this is a lot harder to control because it's not really related to activity, maybe related to stress, it's a little uncertain, but basically instead of the heart just failing to keep up with demand, the demand is going on, but it's the blood supply is changing. So the arteries, instead of being blocked, are actually spasming, and so that's creating a very abrupt change in the blood supply to the heart, and that's also creating the anginal symptoms. This is the one that's going to this often leads to myocardial infarction, though the nitrates can help relieve it, the sublingual nitroglycerin, because it actually, that medication causes vasodilation of the coronary arteries. So those are the three types of angina. So again, angina essentially is the name that we give to the ischemic symptoms that are occurring when the coronary arteries, for whatever reason, aren't supplying adequately the needs of the heart. This is just another picture, a little bit more of a rendering, and it's kind of showing an area which is experiencing a temporary block. Here's the EKG and of angina, and so if you remember, here's our P, QRS, and then here's our T segment, and so that ST segment is a little bit depressed. It's a little bit below the baseline, and we see that consistently on the different leads of the EKG. So as I've said before, I'm not going to show you a lead like this and expect you to do it, but I just thought you might think it's just interesting to see how EKGs can be used to diagnose ischemia. So the second type of manifestation of coronary artery disease that's very common is myocardial infarction. So myo, muscle, cardial, cardiac, so the cardiac muscle. And infarction means there's been a blockage with then death of the tissue. So what this illustration here is showing us is that this ischemia has been prolonged to the point where it has resulted in death of some part of the cardiac muscle. And most often we are seeing a blockage, much as you're seeing in this inset diagram, where the blockage is quite extensive and it has completely blocked the ability of blood to flow. In addition, we could see a partially blocked coronary artery that is not allowing enough oxygenated blood to go through. So let's say we have a person in a sustained activity. They're performing a sustained physical activity, and so over a prolonged period of time, they have a partially blocked artery that cannot serve that part of the heart. So they may also experience it. And then finally, you can always have coronary artery spasm, as I mentioned before, with the variant angina that could, if the spasm was prolonged, could result in a myocardial infarction or a heart attack. So again, just showing you that we can predict what parts of the heart would be damaged by looking at which section or sections of the coronary arteries are actually being blocked. EKG segments, I don't have another picture, but again, the T wave can be enlarged and inverted. We might see ST segment elevation, and again, the Q wave might be abnormal. So these are some possible changes. So with coronary artery disease, we have two choices as far as our manifestation. We know we have blockages in the arteries, and the two most likely outcomes are either angina, or if that angina or ischemia is prolonged, myocardial infarction. So we'll have another video where we talk about how we would diagnose and then the surgical management for those problems. Thanks a lot.